So it's really great to have you all with us today. Thank you very much for attending this webinar. And my name's Catherine. I work in the support services team along with Anna, Annie and Laura. And we're the ones who are at the end of the phone and answer emails when you contact Overcome. So obviously today there's an opportunity to ask any questions that you have. But if after the session today you would like any more information or would like to kind of through, please don't hesitate to get in touch with us. You can call us, email us, send us an instant chat from our website, or we can even arrange a Zoom call if you prefer. So please do get in touch. But I just wanted to share a slide with you before we start today's webinar from Katie and the low-grade serous ovarian cancer patient group. So Katie set up this group for people in the UK diagnosed with low-grade serous ovarian cancer. As Victoria shared, the group is independent of Overcome, but we do work alongside the group to provide support. But this group was set up because they wanted to use their experience to help shape and lobby the medical community to do more for low-grade serous ovarian cancer. The group works alongside Susana Banerjee and others in the medical community to provide a patient voice, and experience of what it's like living with a low-grade serous ovarian cancer diagnosis. The group aims to use their experiences to help shape research and treatments for the future. At the moment, this is a UK-only group, and if you'd like to know more about it, please either contact Overcome and we'd be able to signpost you in the right direction, or send Katie an email at the email address on the slide. But now I'm delighted to hand over to Dr. Susana Banerjee, who will be doing today's webinar, and she'll be explaining some of the basic principles of low-grade serous ovarian cancer treatment and exploring recent developments in treatment and research.
Thank you, Susie. Really unhelpfully, I stopped your sharing when I put up the other slide. So you just need to go back to screen share again. Sorry.
How do I do that?
So bottom of your screen, there's a little share screen button.
Sorry.
Little green one that says share screen.
Thank you very much. Maybe can you see this now?
Perfect. Thank you very much.
Excellent. Can you hear me? Obviously you can. All okay? Perfect. Great. Thank you so much. And firstly, thank you, Victoria, for that kind introduction. And most importantly, it is talking to patients that drives me. It's why I do my work. It's where my team do my work, and where oncologists and researchers working in ovarian cancer. So this is actually an honour for me to talk to patients directly, and families and members and supporters. So thank you, Overcome, to for arranging this, and the low-grade serous ovarian cancer patient group for requesting this. So a little bit about me. I'm a medical oncologist. I trained at the Royal Marsden as a junior doctor, starting in 2003. And I've been a consultant now for 10 years, in a few weeks' time, at the Royal Marsden, treating women with gynecological cancers. So I lead the research in the Royal Marsden for gynecological cancers, and I'm also a reader in women's cancers at the Institute of Cancer Research. So a lot of my work outside of the clinical side is liaising with the scientists and the laboratories, trying to push better drugs through to the clinic. So that's a bit about me. I work at the Royal Marsden in Chelsea in London, and also in Sutton in Surrey. So a bit about the team. Cancer treatment, treating patients, is a team effort. And in particular, with low-grade serous ovarian cancer, it is this multidisciplinary working, and in particular working with the surgical team as well as the oncology teams. Some of you may recognise or know, and I know that some of the team, like Marielle Nobbenvis, has done a talk for Overcome in the past that we see here. The mission of the gynecological research at the Royal Marsden under my leadership at the moment and over the last 9 years, is to save the lives of women with cancer. And that's by developing better anti-cancer therapies to have more long-term remission with a better quality of life, and ultimately to have more women cured. So now I'm going to focus on low-grade serous ovarian cancer. I think one of the most important things to recognise, and I know this audience does, is that ovarian cancer is more than one disease. And I published this with Professor Stan Kay a number of years ago now, 8 years ago, which really looks at a diagram really showing what the key subtypes of ovarian cancer are. So broadly speaking, we talk about epithelial and non-epithelial, and low-grade serous ovarian cancer is a type of epithelial ovarian cancer. So there's high-grade serous, low-grade serous, mucinous, clear cell, and endometrioid are the main types that we talk about. What's the relevance of these labels? Well, different subtypes have different drivers, different molecular drivers, and I think it's not so surprising that therefore there's a different likelihood of treatments being effective. Yet, as you know, all patients to date, at least at the start, receive carboplatin and paclitaxel. There are different targeted therapies now that we think are more likely to work in different subtypes, and there are different outcomes in terms of survival, likelihood of response amongst the subtypes. And I think the key message that we understand a lot more now is that treatment needs to be individualized for patients. So low-grade serous ovarian cancer is a rare subtype of ovarian cancer. It's up to 5 to 10% of epithelial cancers. And data from the Overcome website shows that over 500 women are diagnosed per year in the UK. And what's important is that low-grade serous ovarian cancer can arise from a benign condition called serous borderline tumours. It affects women of all ages. It's most common in the 40s and 50s, but unfortunately we know all too well it can happen in older patients and also younger patients as early in the 20s and 30s. So compared to some other forms of ovarian cancer, traditionally, low-grade serous ovarian cancer is less responsive to chemotherapy, and generally there's a longer survival for patients with low-grade serous ovarian cancer compared to some other subtypes. But I must say that in my clinical experience, there really is a spectrum. Unfortunately, there are some patients with low-grade serous ovarian cancer where the cancer moves far too quickly, whereas with others, it can have a more indolent course. So what do we know a bit more about with low-grade serous ovarian cancer? And it's always important now in this era of targeted therapies and molecular profiling and all the knowledge we know from the labs to look at the molecular makeup of low-grade serous ovarian cancer. So this subtype of cancer is noted to have alterations in certain pathways and certain mutations in genes called KRAS, BRAF, NRAS, and also HER2 or ERBB2 abnormalities. We also know that the majority express hormone receptors, so for example, the estrogen receptor. And what's really important, because we hear a lot about BRCA and BRCA mutations and PARP inhibitors, but for low-grade serous ovarian cancer, BRCA mutations are very rare and arguably not present. And I would always say to check the histology, in particular if one finds a BRCA mutation in what's perceived to be a low-grade serous ovarian cancer. So surgery is key for the management of women with low-grade serous ovarian cancer, not only at diagnosis and the first-line situation, but also for recurrent disease. Chemotherapy plays also an important role, and targeted therapies include hormonal therapy approaches, so anti-estrogen approaches, anti-angiogenic agents such as bevacizumab, and also what's now at the forefront of treatment for low-grade serous ovarian cancer, drugs called MEK inhibitors, and I'll discuss that in a few minutes. So I mentioned at the start, the key for the best management and best outcomes for women with ovarian cancer, and in particular low-grade serous ovarian cancer and rarer cancers, is multidisciplinary team management. That involves the pathologist, the oncologists, the surgeons, the radiologists, the clinical nurse specialists, and a whole host of other specialists, including community doctors, the general practitioners as well, because in rarer cancers, some may never have seen this form of cancer, and so it's really important to gather as much information and expertise from specialists. So the MDT, the multidisciplinary team meeting approach, ensures patients receive optimal care based on best practice and evidence-based guidelines. I would always, and this is a great forum to consider surgery, and also consider referrals for clinical trials. We know that not all cancer centres will be able to offer clinical trials in every type of cancer, and therefore it's really important to be aware of what clinical trials may be going on in low-grade serous ovarian cancer and where patients can be referred. So I mentioned surgery, and I think that's really key, as I say, for management. And ovarian cancer surgery to remove all disease is one of the best predictors of outcome. And access to surgery in specialist centres at diagnosis and at recurrence is important. Now, I mentioned earlier about younger women who unfortunately may be diagnosed with this disease. Fertility preservation sometimes is possible, but it really depends on the extent of disease. And this, courtesy of my consultant colleague, surgeon Mr. John Butler, is an example of egg harvesting at the time of removal of the ovaries with egg freezing and preservation of the uterus. So what about drugs? Firstly, starting in newly diagnosed ovarian cancer in the first line setting. Well, as you may know, or what you may hear or read about, what's said is that the response rate to chemotherapy, so for example, carboplatin and paclitaxel in the first line setting, is not as high as we'd like it to be, or indeed other forms of ovarian cancer such as high-grade serous. So it's noted in the literature as under 25% likelihood of shrinkage. What I will say is that I certainly do use chemotherapy in the first line setting, and I, as I'm sure others, have seen patients with low-grade serous ovarian cancer benefit from treatment too. So it is something that's really important to consider, but we acknowledge that the likelihood of shrinkage needs to be better. One of the problems with rarer cancers like low-grade serous ovarian cancer is the lack of prospective trials designed to look at as many women as possible with this specific disease, and then so that we can answer the question about what is the value of chemotherapy, what does it add in terms of survival. So a lot of our understanding and evidence is actually based on experience, based on people publishing from their hospitals or groups, and also analyses of larger clinical trials that will include some patients with low-grade serous ovarian cancer. And looking at those, in one of the studies, it looked like that first-line chemotherapy versus no chemotherapy, that there was no significant difference in survival. Another study, a very important agent called bevacizumab or Avastin. This drug attacks blood vessels that feed cancer. It is an antibody against a molecule called vascular endothelial growth factor. And within actually the ICON-7 study, which was led by the UK, we noted, it was noted that in the first line, with bevacizumab is added to chemotherapy and continued as maintenance therapy, that there is an improvement in time to cancer progression within low-grade serous ovarian cancer. And what about first-line maintenance hormonal therapy? So there was a very important retrospective, so going back to patients treated in the past and looking at those who may have been treated with hormonal treatment or not. A very important finding was that the time before cancer getting worse appeared to be longer in women that had hormonal therapy. But we acknowledge as a community that we need to see this in clinical trials so we can assess the benefit, the true benefit and the magnitude of benefit. And that trial is ongoing in the US. So what about recurrent disease? Well, chemotherapy also remains an option. Now, again, in the historic literature, what's noted is that response rates are low, under 5% in what is deemed platinum-sensitive disease, which means cancer that's come back within 6 months of carboplatin, or indeed, sorry, more than 6 months of platinum-sensitive or less than 6 months of platinum-resistant. With hormonal therapy, and by that I mean drugs like tamoxifen or letrozole or anastrozole, the response rate is higher than chemotherapy in the retrospective literature at about 9%. And bevacizumab containing regimens, so usually that's with chemotherapy, the response rates, again in these series from hospitals, is higher at over 40%. What really changed the field was this US study of a MEK inhibitor called selumetinib, and the response rates were 15%, which was higher than what we've seen in chemotherapy and hormonal therapy. And that really fueled the progress of studies looking at MEK inhibitors, and I'll talk about that now. But before I do that, I want to talk to you about how do I treat low-grade serous ovarian cancer currently, based on what I've just said. So at diagnosis, always consider for all patients surgery to remove all disease. And even if there's a bit of cancer, what we call low volume disease left behind, there may well be benefit for patients. And we noted that in the ESMO-ESGO consensus meeting, which I was part of a few years ago. And then considering first-line chemotherapy, so that's carboplatin with paclitaxel, for the most earliest stage, so stage 1, you can discuss no chemotherapy, for example, for stage 1A. But for stage 2 and above, I always discuss the role of chemotherapy. And that's in keeping, again, with the ESMO-ESGO consensus guidelines. These are European guidelines of over 40 experts in the field. And then for more advanced disease, stage 3 or 4, I definitely offer chemotherapy, carboplatin and paclitaxel, and also the addition of bevacizumab followed by maintenance bevacizumab. And that is available in the NHS through the Cancer Drugs Fund. The indication for bevacizumab doesn't specify the subtype of epithelial ovarian cancer. I don't recommend PARP inhibitors because the evidence for PARP inhibitors is in high grade, not low grade disease. And as I mentioned to you before about the lack of BRCA mutations driving low grade serous ovarian cancer. So what about follow-up? Well, CA125, I always do that in my practice, but it's not as informative as, for example, in high-grade serous ovarian cancer and other subtypes. So I do monitor the CA125, but I also recommend CT scans as well. But I appreciate that there may be differences in practice. So what about at recurrence or when disease worsens, so progression? Again, I always consider surgery to remove all disease. Even if some disease is left behind, I consider chemotherapy, so either platinum-based or other chemotherapies such as weekly paclitaxel, and re-challenge with chemotherapy more than one time. Hormonal therapy such as letrozole or anastrozole or tamoxifen. And also one of the complications of ovarian cancer in general, but also low-grade serous ovarian cancer, is bowel obstruction. And in specific circumstances, I do consider, as a multidisciplinary team working with the dietitians and nurse specialists, TPN, so that's peripheral nutrition. And I always consider and always have done clinical trials for this disease, given the likelihood of benefit with conventional treatment. So at this point, I'd like to break the theme in terms of me talking about responses to treatment and about raising awareness for low-grade serous ovarian cancer. So this is actually my patient who you may know or you may have read about in the Daily Mail earlier this year. And it really highlights, and I know how difficult it is to talk about experiences, but really highlights rarer cancers that may not get the exposure and profile which is needed in this disease. You can read this at your leisure, but it really highlights the need for better treatments and what patients go through, like yourselves, in the journey of a diagnosis and the experiences that you have. So, how are we going to improve things? Well, new treatment approaches for low-grade serous ovarian cancer. I mentioned MEK inhibitors. And so, put simply, that there are pathways within a cancer cell that are activated, and that's what drives cell growth, cell spread, it's cancer spread, and also allowing a cancer to just perpetually live and grow rather than die. And so there are certain mutations. I've mentioned KRAS, NRAS, BRAF, which is around a third of women with this type of cancer. And by blocking these molecules, we hope to stop the cancer or slow it down in its tracks. So I've always been very interested in improving treatments in the low-grade serous ovarian cancer, and I was privileged to be involved in 2 phase 3 trials specifically in low-grade serous ovarian cancer. I'll mention them here. The first was the NGOT-OV11 or MILO study, and this was of a MEK inhibitor called binimetinib. And patients with low-grade serous ovarian cancer that had recurrent disease were randomized to receive this MEK inhibitor or physician's choice of chemotherapy, as listed here. We've published this work and presented it. There was no survival difference in the MEK inhibitor treated patients versus chemotherapy. The response rates were around 16%, which would be in keeping with what I said to you before with the MEK inhibitor. But what was so important about this trial was actually for the first time prospectively seeing what the true value of chemotherapy may be. Because I mentioned to you before that in the literature, response rates were under 5%, and here it was a little bit higher at 13% with chemotherapy. What was really interesting was when we look at the subgroups of women with low-grade serous ovarian cancer, and those that had a KRAS mutation, as you can see here, had a longer time before cancer worsened compared to those that don't when they were treated with binimetinib, so around 17 months versus 10 months. Now I'm going to move on to the other trial that I was very pleased to be involved in and open at the Royal Marsden. This was a US-UK study through the NCRI of trametinib in low-grade serous ovarian cancer, so recurrent disease. In this study, patients couldn't have had a prior MEK inhibitor or targeting those pathways, but they could have received prior chemotherapy and hormonal therapy. And patients were randomized to trametinib or the doctor's choice, and the team's choice, and the patient's choice of standard of care, which included chemotherapy or letrozole, and patients were treated till progression. So I know this is a busy slide, but it's more for me to let you know that the response rate to trametinib was 26%. And in the control arm, so in the standard of care options that we have in the clinic, overall it was 6%. Now with hormonal therapy, if you look at the breakdown there, letrozole, it was 13%. With paclitaxel, it was actually 9%. Interestingly, in this study, tamoxifen was 0%. So overall, in terms of response and response duration, which was much longer with trametinib compared to the control arm, this was a very significant improvement. So looking at this in a different way, the average time before cancer got worse, as a progression-free survival with trametinib, was 13 months versus 7 months in the standard of care arm of chemotherapy or indeed letrozole. And with overall survival, this was longer as well with trametinib at 37 months versus 29 months. Whenever we're thinking of treatments, we need to balance this with side effects, because we need to make sure that the quality of life of our patients going through these treatments is warranted given what I've just said in terms of outcomes. So with trametinib and MEK inhibitors in general, skin rash, fatigue, diarrhea are aspects that we do need to manage well. In this particular trial, around 35% of women discontinued treatment due to side effects or adverse events or complications with the trametinib arm, compared to 12% with chemotherapy. So now moving on to other trials, not only within the UK, but open globally in other countries. It's just really to give you a flavour of where we're going in terms of treatment progress. So I mentioned to you exploring hormonal therapy, so letrozole in the first-line setting as a maintenance therapy, and that trial is underway in the US. There's also a trial of maintenance therapy in Europe that is open, and specifically with a sub-study for low-grade serous ovarian cancer. There's also a study of a drug that's targeting the progesterone receptor in low-grade serous ovarian cancer. Another study looking at other targets and combining this with hormonal therapy approaches, so CDK4/6 inhibitors. And I'd like to focus on for the remainder of this lecture on the study we have open in the UK, the RAMP 201 study, and that's a phase 2 study that I will talk a bit more about now. It's open in the US and UK. We're currently open at the Royal Marsden, and we'll open other sites, and we will open in Spain, France, Italy, and Belgium, and Canada shortly. So this was the latest update, which I presented a few weeks ago at the European Society of Medical Oncology Congress in Paris. And it was great to be at the first live meeting face-to-face and actually traveling for a meeting and presenting work on low-grade serous ovarian cancer. So this is on behalf of co-authors. This is an academic study sponsored by the Institute of Cancer Research. So I've already told you, and what I said to the audience to remind people about the seriousness and the significance of why we need more treatments for women with low-grade serous ovarian cancer. So the response rate to MEK inhibitors range from 15 to 26%. We've seen the progress with trametinib compared to standard of care, with a progression-free survival of around 13 months versus 7 months. We noted the adverse events in terms of side effects, and that also patients with a KRAS mutation in the MILO study with binimetinib had a longer progression-free survival. So what I wanted to get the point across, and also today, is that low-grade serous is a subtype of ovarian cancer that's driven by this pathway called RAS or MAP kinase. Around 30% of women may have a KRAS mutation, and 70% have activation of this pathway. So I know this is busy, but all I want to say is that there's lab research that led to this clinical trial. If we are going to make progress and try and stop these cancers from becoming resistant to our mechanisms of attack, we need to be a step ahead and more clever, and we need to address multiple resistant mechanisms. And that's what this trial is one mechanism of doing that. So VS6766 not only inhibits MEK, but it also inhibits a molecule in the same pathway called RAF. And combined with something called a FAK inhibitor, we've seen in the lab and also in ovarian cancer models that we can get more robust shrinkage, in particular in low-grade serous ovarian cancer models and KRAS mutated models. So here are the results that we presented. This was of the FRAME study that some of you may know of or been part of, and thank you to you. This is of 24 patients, specifically with low-grade serous ovarian cancer. There are a couple of slots left within this study. The overall response rate was 46%. And importantly, in patients with a KRAS mutation, that response rate increased to 64%. For patients that didn't have a KRAS mutation, the response rate was very notable, 44%. And importantly here, what I'd like to make the point is that we saw responses in women who had previously been treated with a MEK inhibitor. Meaning that this combination may well have value also in patients that have previously been treated with, for example, trametinib. So far, and although this is an early phase study with a small number of patients, the average, the median progression-free survival as it stands at the moment is 23 months across all patients with low-grade serous ovarian cancer. And what you see in these graphs, when I look at the responses there, if you look at the colourful arrows that we have there, that indicates whether there's been some shrinkage or not. As you know, for far too many women, disease progression or growth of cancer would occur, which would be above the 0 in that line. I'd like to share with you an example of a woman treated within the FRAME study. This lady was 77. She had low-grade serous ovarian cancer, treated with surgery back in 2010, had carboplatin and paclitaxel, and then doxorubicin, then had further surgery in 2011, and then had some lines of hormonal therapy, letrozole and tamoxifen, as you can see there. And then from January 2018 to the present, this patient has been treated within the FRAME study on VS6766 and defactinib. And what I'm showing here is CT scans from January 2018 to July 2021, which basically shows shrinkage of this low-grade serous ovarian cancer, which has been maintained at this point. So the key message that I had in this trial is that this appears promising. This is an oral combination. So far, only one patient has discontinued for an adverse event to date. The response rate that I just highlighted to you is encouraging. And in May 2021, the FDA in the US granted breakthrough therapy designation based on this study results for VS6766 and defactinib for the treatment of patients with recurrent low-grade serous ovarian cancer, having had one or more prior lines of therapy, including platinum. This means that the FDA are very keen to push through approvals and access, providing that more activity can be seen. And that led to this registration-directed clinical study in low-grade serous ovarian cancer, which I'm delighted to be the global lead of, based on the work that we've done so far, called NGOT-OV60 GOG 3052, or simply RAMP 201. And we're currently enrolling, as I say. This is the trial design. I know it looks complex, but I'm going to talk you through, because the main points is that it needs to be patients that have had recurrent disease. You're allowed to have had a prior MEK inhibitor, and there's no placebo in this study. All patients will either get VS6766, so the RAF MEK inhibitor, either alone or with defactinib. And the reason for this is that if we can achieve the same amount of success in terms of responses and duration with one drug rather than the two, then that will be very attractive when we also balance side effects. So we need to explore that. So all patients will be receiving treatment, no placebo, as I said, and we'll be dividing patients according to the KRAS mutation status. So in the UK, in order to deliver this, all patients can have their tumour tested and also blood sample if tumour is not available at the Royal Marsden, irrespective of where they are nationally, as part of this study in order to facilitate this. And this really is an international collaboration. So I'd like to more or less end with, again, another press highlight, because based on the results that I just showed you, I was delighted to see the coverage in The Guardian, The Times. I was speaking at LBC on this FRAME trial. It highlights the need and highlights low-grade serous ovarian cancer, and I very much hope that there'll be more to come and more coverage in the future highlighting this rare disease. So to end, we know that chemotherapy and hormonal therapies are options, but we need to do better with our treatment outcomes. There are new biomarkers that we need to see how they pan out in trials. MEK inhibitors do represent a novel option. They're not licensed through the FDA or EMA yet, but trametinib is to date currently available still via this Cancer Drugs Fund during the COVID-19 period. Patients cannot have had a prior MEK inhibitor, need to have had prior platinum and hormonal therapy. I very much urge patients, clinicians, nurses, everyone who knows about and is part of managing this disease to consider clinical trials. And as I said, we have the RAMP 201 study now open in the UK. So what are the next steps? Well, we need to improve treatment options. I've talked about clinical trials. The FRAME trial that I just presented, we have a few more slots, but equally RAMP 201 with the same treatment. So please raise awareness, please refer patients. That's my secretary's details. There is the Rango study that Marcia Hall talked via Overcome some time ago with regards to rare cancers and also low-grade serous ovarian cancer in terms of samples. I'd like to also highlight some other new projects. So the Lady Garden Foundation funded a project that I'm leading, which is specifically in low-grade serous ovarian cancer, really looking at biomarkers and outcomes, looking at blood samples for KRAS mutations. Because wouldn't it be good if we could pick this up in the blood rather than biopsies and actually monitor patients' progress on treatments going forward? Also, I'm very much interested in patient experiences and quality of life. And so there is a project linked to outcomes and biomarkers under development that I'm talking with the low-grade serous ovarian cancer patient group that you heard about earlier. So please contact them. I'd like to end in acknowledging you, patients, families and friends, the research teams, Overcome facilitating this, the patient groups, and of course funders of WIAMS here at the Marsden Institute of Cancer Research. So thank you.
Thank you very much, Dr. Banerjee, for such an interesting and informative talk. As you can probably imagine, we've had quite a few questions that have come in, so if it's okay with you, I'll start with those. The first question that we have is, in the UK, they don't do PET scans for low grade. If someone has symptoms that are unexplained and could be a recurrence, is it always best to wait until they show on CT rather than go in with exploratory surgery?
Thank you for that question. I'm sure others have similar questions, regarding scans. So I would say that with PET CT scans can be very helpful for some forms of cancer, including ovarian cancer. But with low-grade serous ovarian cancer, it's not always helpful because of the low-grade activity that the PET CT scan may not pick that up. So the reason why CT scans can be valuable and the modality that we use is because with low-grade serous ovarian cancer, it's often what we call calcified. There's hardening of the cancer, which really can show up well on a CT scan. Now, I also do use MRIs as well of the abdomen and pelvis, because I don't think there's just like one test that's going to be right for all patients at all points in their journey. So an MRI can be helpful in looking at disease around the bowel, for example, and I think it complements the CTs. But in answer to your question about if you have symptoms, whether to go, or did you say exploratory surgery, Catherine? Is that right?
Oh, yes. Yes. Right. So it said, yeah, it's best to wait until they show on the CT rather than going with exploratory surgery.
Okay, so I think it's really important that patients are followed up more closely and assessed by the surgical team and oncology team with more if they have symptoms that are persisting. But we also need to acknowledge that surgery itself has its fair share of side effects, and having a laparotomy, for example, and unnecessarily, and the consequences following that and the recovery really needs to be balanced. So I would say that the timing of surgery really needs to be managed, working with the oncology teams, patients, and the surgical teams with the appropriate imaging.
Thank you very much. You've partially actually answered the next question, but I'll ask it in case there's anything additional that you'd like to add. But is it true that low-grade serous ovarian cancer doesn't always show up on a CT scan, and would an MRI be more effective?
So again, I think it's really about using the right modality at the right time. I often see, patients, when you're not quite feeling right, and it may not show up on a scan yet. It may not be reflected on the CA125. And in those circumstances, what we usually do is stay in touch and have a follow-up appointment, perhaps a bit sooner than what would be regularly scheduled, in order to assess again and also bring scans forward, because at some point there will be changes on a scan. And as I said, if they, for example, were more bowel-related symptoms, then I would, potentially do an MRI of the abdomen and pelvis there.
Thank you very much. The next question we have is it possible for letrozole to prevent low-grade ovarian cancer from ever coming back?
Well, this is the question. So we need to balance when to use our treatments along the patient journey. So the trial that is recruiting in the US and also across other ovarian cancers within Europe is really asking the question whether drugs like letrozole may delay the time before cancer comes back, or indeed prevent it from coming back. We also need to acknowledge that although side effects of hormonal therapy may be different to chemotherapy or indeed MEK inhibitors and targeted treatments, that there can be, lowering the estrogen levels further can have effects. For example, we need to make sure osteoporosis is managed, perhaps potential joint pains, for example. And to date, we don't have the complete evidence that giving letrozole in a preventative manner for relapse is efficacious. But I do think we need to use hormonal therapy at some point in the disease course.
Thank you very much. We've had a few questions about bevacizumab, Avastin, along the similar lines. So one of those questions is it likely that Avastin would ever be approved on the NHS for low-grade ovarian cancer?
So what I said in my talk is that bevacizumab is available in the NHS through the Cancer Drugs Fund in the first-line setting. It doesn't specify that it needs to be, that it's not for low-grade serous, for example. It's epithelial ovarian cancer. So that includes low-grade serous ovarian cancer. So bevacizumab is not available in ovarian cancer, irrespective of whether it's low-grade serous or not, in the NHS in recurrent disease. Okay, so that's an issue, irrespective of low-grade serous ovarian cancer. It's also important, individualising the decision for bevacizumab, because one of the problems of bevacizumab is that it can cause bowel perforation and also something called fistula formation, which is an abnormal communication between the tumour and, for example, the bowel, which one would like to avoid if at all possible. So if there's bowel obstruction, for example, or risk of bowel obstruction, which can occur with low-grade serous ovarian cancer, I would not be recommending bevacizumab in those settings. So it's really about tailoring the treatment at the right time in the pathway.
Thank you very much. So another question we've had is, how should people with low-grade serous ovarian cancer choose between watch and wait or hormone maintenance treatment when there is no evidence of disease?
And this is the challenge. This is why we need to do clinical trials. This is why we need to come together and also report on individual experiences and collate that information, because I know that obviously there'll be patients and that have a watch and wait, and some people go on chemotherapy and some may have hormonal therapy. So it wouldn't be good to collect this information so that we can find out what the UK experience is. It is such a difficult decision. It needs to be shared and it needs to be led through the consultations with your oncology teams. But even having said that, it's that uncertainty because of the lack of evidence either way, and it's explaining that and coming up with a decision that patients and teams are comfortable with. And I think the key thing is that often people feel that watch and wait is not doing anything, but monitoring carefully, being alert for symptoms, being alert for changes in the way you feel, and having regular assessments with the oncology team is active as well. And I think that's important. And so it's about either potentially using up a treatment, earlier on when there's no disease present, when we don't know if it's going to make a difference or not, or reserving it for later. As I said to you, I do recommend post-operative or adjuvant chemotherapy, for example, and bevacizumab for advanced disease.
Thank you very much. A question actually that has been covered, but I'll ask because it's complete. What is the most successful treatment for low grade right now?
Okay, so I'm pleased that we are living in times where progress is being made and trials are being done, whatever the outcome, because previously there weren't trials specifically for women with low-grade serous ovarian cancer, and therefore this wasn't looked at. So I'd say right now, MEK inhibitors and combinations of MEK inhibitors, like I said, within the RAMP 201 study, is probably the most promising and exciting. And also combination studies of hormonal therapy with other targets, I think will be a very interesting approach. This approach is being used, for example, in breast cancer, a completely different disease, but also that maybe obviously is driven by hormones and for some patients too. So I think that would be an interesting approach too. Maybe combining MEK inhibitors with drugs like bevacizumab.
Thank you very much. So we've had lots of questions about the RAMP 201 trial. So I'll start off with some questions about those, if that's okay. So a couple of people have asked how to join the trial, perhaps living in the UK, living in Sweden or Denmark.
Okay, so first of all, we opened in the US some months ago, but this year, and I'm just so delighted that just a couple of weeks ago in September, we've opened in the UK, and it's been a really challenging time, as you can imagine, Brexit, COVID, and opening trials within the UK. So I'm just so pleased this is open now. So the first centre to open is the Royal Marsden. We take patients from all over the UK, and we did, the issue is travel, travelling to London or Surrey. So, but we do accept patients from all over the UK, and we have treated in the past with studies that may not be open elsewhere, patients travelling all the way from Scotland for these treatments. This is a study that's sponsored by Verastem, which is the company, and therefore there is importantly some reimbursement for travel expenses and hotels and such if one needs to stay the night given the distance to travel. We will be opening in Edinburgh, Glasgow, Manchester, and UCLH as well. So, so there will be other centres. Now, in answer to your question about other countries, I mentioned that we will be opening in Spain, France, I think it's Belgium, Italy, and also Canada. Now, within the EU, I understand from when I talk to patients that come and see me internationally, or when I talk to my international colleagues, that patients can travel or may be able to travel from their countries to other countries. That's not the case in the NHS, from what I understand. So I would suggest in patients in other countries to contact the countries that I mentioned in the leads. But the information will be on clinicaltrials.gov internationally for the trials, and I'm happy, as global lead, to be contacted and direct you to Verastem or find out the answers as well from the sponsor. And in answer, sorry, I didn't answer your other question about how do you get into the trial. That's the most important bit, isn't it? So please ask your GPs or your oncologists to refer. I look at every referral, and I will see whether the trial may be an option, and also I often say, because some of you may have seen me or had consultations with me, just because we have a trial, I don't always recommend it, because I may think that there may be a different option for you that might be better at your particular point in the journey. You know, for example, if cancer hasn't got worse and is responding to the current treatment that you're on, let's make the most of that treatment for as long as possible. I hope that answers your question.
Thank you very much. Another question that came in is there a deadline for this trial?
So for the RAMP 201 study, the deadline is when we finish recruiting women with low-grade serous ovarian cancer. So we're expecting over 120 patients or so to be enrolled. We are not near the end. We've just opened in the UK, as I said, and about to open in Europe. I think to date there's around 25 patients enrolled, around that number from the US. So there certainly are slots. We will make it clear when we're close to the end as well, so that people are aware. But I think one of the frustrations for us all with studies that are in rarer cancers, that we need, the reason why some studies don't exist or haven't existed to date is actually the perception that there aren't enough patients to go in, or it will take years to recruit to. But I don't believe that's the case, and we've shown that with the other 2 low-grade serous ovarian cancer studies. And so I very much hope that we can get the answer, so that hopefully, if this is effective, this can be approved in a timely frame, which is dependent on recruitment.
Thank you very much. I think we've probably got time for one more question. I'm sorry to those of you who haven't got to your question. Dr. Banerjee's really kindly offered to look at them at the end, and we can send a response out after today. But it's just, I think we've got time for about one more. The question is, you make no mention of radiotherapy. Is this not effective for recurrence?
Okay, so no, that's a really interesting question. I do like that question. So I'd say increasingly so, we are considering radiotherapy in ovarian cancer. So I'll just say ovarian cancer in general, and then for low-grade serous ovarian cancer. And I work very closely with the clinical oncology colleagues and consider radiotherapy if there's a localized area rather than widespread disease, because if there's more widespread disease, then radiotherapy is a localized treatment, and therefore it's not really going to be effective, and also balancing the side effects of radiotherapy as well. So definitely for specific cases like with surgery, I would consider radiotherapy. Anecdotally, and that's why I really think it'd be really good, again, as I say, in collecting experiences of patients, so we can hear if people have had radiotherapy and it's been effective. I haven't seen such dramatic responses in low-grade serous ovarian cancer with radiotherapy compared to some other forms of ovarian cancer.
Thank you ever so much, Dr. Banerjee, for such an interesting session for us all, and thank you very much to everybody for attending and for all of your questions as well.
I hope I get invited back at some time to talk again.
We'd love that.
Yeah, we would.
Literally, we could just put you on repeat, give you a new subject every week, Susie. It would be great. Thank you very much for your time. Now, to those of you, just to reiterate, those of you who we have not answered your question, who've not had your questions asked today, the support team will be in touch with you over the next week, so starting Monday, with responses, and noting the number of people that have sent in private messages and also more public messages asking about how to get onto the trial. We will send that, we'll send all of that, how to get onto the trial, how Susie's or clinic details, how to get a referral, the name of the trial, all of that will come out to everybody that's attended today. So we'll make the assumption that everybody wants that information. If you can then pass that on, or we'll also be sharing some of that information from Susie on some of our social media channels and through our community news channel as well. So if there are people who you know who have not been able to join this call or this webinar, please do let them know that, you know, and pass that information on, because as Susie said, the greater the patient numbers that actually hear about the trials and what's going on, the better, because it's going to take us a couple of weeks to format this webinar and put it out as a recording. So we don't want any delay in information from that, okay, in information reaching patients. Susie, thank you so much for your time. And I think that's us now. Have a great weekend, everybody.
Thank you
Very much indeed. Bye-bye.